Hi, good morning or good afternoon. I don't know when it's going to be presented. I want to thank you, Aspire, for the invitation to bring me here. And the topic that I have been in charge to discuss with you, you have it here in the monitor, is about the non-invasive PGT-A and to analyze what does it offer to the patients. First, I would like to just disclose my conflict of interest. I have many tasks that I'm doing, but the most relevant for this presentation is the fact that I am the founder and the head of the scientific advisory board of Igenomix, which is a company from which we have been doing research from the bench to the bedside, and non-invasive PGT-A is one of the projects that has ended in a test that I'm going to present today. So you have to know this to understand any bias that I might have for that. As an introduction, what I would like to just have the frame of the presentation by the fact that the human embryo aneuploidy testing have been evolved for the last almost 30 years, in which it was a starting point using fish for several chromosomes with day 3 biopsies with those blastomeres, then move to the biopsy, to the trophectoderm biopsies, and then using technically systems that allow us to analyze all the chromosomes for the karyotype using comparative, CGH, SNPs, or even PCR. Lately, next generation sequencing has been included as an evolution, as a technical evolution that allow us to do not only the diagnosis for the whole karyotype, but also we have been able to identify mosaicism, we have been able to add specific mutations, and nowadays it is the one that is being used. And the next step is what I would like to discuss with you today, because PGT-A, with all of this evolution, there are still two main questions to be answered. First, there is the criticism that to do this analysis, we need to do a trophectoderm biopsies. And those biopsy of the embryo may impair the ability of the embryo to implant and may affect somehow embryonic development. This has been one of the criticisms. And the other is that sometimes we may discard embryos that otherwise will be able to go to it. So to address these two main criticisms is why we and other groups has been working in the concept of analyzing the cell-free DNA secreted by the embryo in the conditioned media, in the culture conditioned media. So the point is like that. The actual invasive PGT-A is by taking a biopsy of 3 or 5 to 8 trophectoderm cells, and by NGS, we are able to understand what is the profile, the chromosomic profile of the embryo. And the challenge is to move this analysis without really biopsying the embryo, without touching the embryo at all, just analyzing the cell-free DNA secreted to the conditioned media in which the embryo will be cultured the last 40 hours prior to be transferred to the endometrial, to the uterus. This is not a new concept. In fact, non-invasive PT has been changed the way that obstetrics is being done, that prenatal diagnosis is being done. As you know, the analysis of the cell DNA, of the cell-free DNA secreted by the placenta has changed the way that we do prenatal diagnosis, NIPT. And amniocentesis is used nowadays just to verify alterations, but not anymore is the first line to analyze this. So somehow this is the idea, analyzing embryo cell-free DNA that can give us what is the reflect of the chromosomal status of the embryo. We are just one group that has been working on this type of research. Here you can see what is the evolution of this field in the last 4 years, trying to verify this concept from a very low concordance rate between the results obtained by trophobectoderm biopsies versus cell-free DNA through a reasonable 80% concordance rate that is being nowadays. Different authors has been trying different approaches, but somehow they have been either do hatching, vitrification, some biopsies. So our attempt has been to really try to analyze the embryo without any intervention, mechanical intervention whatsoever to the embryo. Being aware that the two main difficulties here is the maternal DNA contamination that can somehow obscure the diagnosis and the embryo mosaicism. So this is what we have done in the last 6 years on this field, in which we start to understand the origin and composition of cell-free DNA. We published this in 2008. And so we did the proof of concept that it exists. However, the concordance was very low. Then we moved to a first clinical trial pilot study, trying to verify this in a cohort of about 100 blastocysts. And then now we have been performed a multicenter clinical trial in 1,301 embryo by trying to realize whether this system could be clinically solid or not. So just let me go very briefly of our evolution of that. So in the first proof of concept, what we did is to really observe that the cell-free DNA was present in the sperm culture media with the embryo. It exists versus the control, and the concentration of this cell-free DNA was similar in euploid or aneuploid embryos, or in female embryos. And this has been seen in non-amplified samples, but also in samples after amplification. However, in our first attempt, the concordance rate that we found between trophobectoderm biopsies and sperm culture media of the same embryo, with this number, 56, was very low, was only 30%, with a huge maternal contamination. So we just, at this moment, as you can see in the paper, our conclusion was that it was not ready for the prime time, so we should improve this in order to really have a clinical impact. And this is what we did. So in the second paper that was published last year, our aim was to improve IVF conditions and the NGS protocol to be more specific about the detection, to estimate what is the optimal time for media correction, and also to assess what is the clinical impact of that, what is the impact of the clinical outcome of those embryos that they have been analyzed with cell-free DNA, and what is the concordance between that. So this study was published last year and was performed together with Laura Rienzi and the Genera group in Italy, Dr. Filippo Baldi, with a number of embryos, was 115 blastocysts, in which we define, we just culture them, and we obtain the condition media at day 5 and at day 6, and trying to see what was the concordance. So what we realized is that the concordance at day 5 was 63, but at day 6, we already have a 84% concordance with 100% informativity, which means that it was, something that that was very nice to see in order to have the field moving forward. We learned also that the concordant, this was especially important at day 6, and we don't call them anymore false negatives and positive, because when they were discordant, this is the clinical results that we found. This is just a small series that was published when we have single embryo transfer coming from euploid trophobectoderm biopsy that later on, when we analyzed retrospectively the cell-free DNA, we realized that they were concordant, both of them. In this case, they have a very nice clinical pregnancy and ongoing implantation rate. However, when the trophoectoderm biopsy was employed, but we realized that the sperm blastocyst media was unemployed, we have more clinical miscarriage, and therefore ongoing implantation rate was reduced. Therefore, the fact that it means that maybe the information gathered from the ball of 100 cells could be even more precise than the fact that they are giving us just 5 or 6 cells. So this was something that we want to pursue because we use a trophoectoderm biopsy as the gold standard, but maybe we have a room for improvement by adding the conditioned media, the cell-free DNA secreted by the embryo. So that's why we moved to this multicenter clinical trial published a few months ago in the American Journal of Obstetrics and Gynecology. This study was performed in these 7 centers, and we analyzed 1,301 blastocysts, both the trophoectoderm biopsy and the cell-free DNA from the sperm blastocyst media. And also we biopsy a subset of them, trying to see what is the association between cell-free DNA and inner cell mass and trophoectoderm. This is the hypothesis of this study. This is the clinical trial registration. Our hypothesis was to have a concordance of about 80%. And that's why every embryo that was analyzed with the trophoectoderm biopsy, prior it was obtained the conditioned media, the sperm blastocyst media, to analyze the cell-free DNA. And this is again the centers that they enter, and we have already agreed to have the interim results analyzed. This is the paper that I'm presenting to you. So in all of these 8 centers, it was a mean of 78.2% concordance, with centers with as high as 86% and those with 72.5% of concordance. Here you can see sensitivity and specificity of that. We found that there was a higher concordance as the patient ages. So the concordance increased when the female age was higher, because you may expect higher aneuploidy rates, and in this case, concordance is more accurate for that. The other important issue that we found is that there were no significant differences in cell-free DNA diagnosis according to the culture media. Every center used different culture media that they were using routinely, so there were no differences about that. Neither were differences in the incubator model that different centers they were using throughout this study. Therefore, this makes us talk about how solid this analysis could be. We have also a subgroup of 81 aneuploid blastocysts that they were donated for research within this study. And in those blastocysts, what we did basically is to biopsy the trophoectoderm, the inner cell mass, and we compare with the result of the cell-free DNA previously obtained. As you can see, the concordance of cell-free DNA and trophoectoderm biopsy was 87.5%. Cell-free DNA versus inner cell mass is 84.4%, and trophoectoderm versus inner cell mass was 87.5%, meaning that really the concordance it's quite consistent, and it remains to know where is the origin, but it looks like the concordance is quite good in all of them. Now, after that, we try to, so this was the first part to avoid any invasive manipulation of the embryo. Second was to have a workflow of a prioritization system that allow us to transfer embryos according the results, informing patients and doctors. So it is trying to avoid discard unnecessary embryos. To do so, what we did first is to define thresholds for ploidy. It was based on a mathematical calculation in which the cutoff values of each chromosomal abnormality when compared with trophectoderm biopsies. Second, we estimate an euploidy score for each embryo, and it was done according to the aneuploidy number, whether they were whole or segmental abnormalities, gains or losses, etc. And finally, we established an embryo priority, in which embryos with cell-free DNA with higher euploid score are given priority for transfer. And by doing this, we just end up with a report like that, which basically prioritizes first euploid and then aneuploidies according to the factors that I already indicated, giving the lowest score, of course, to single trisomies. And then you are getting here what is the priority, the embryo priority for your patient that you are going to have. Of course, it's not the same to have several euploid embryos in a patient with 37-year-old or the only embryo in a 44-year-old woman in which you have got this embryo after 2 cycles. So that's why this prioritization system aims to give all the information to make a reasonable diagnosis and treatment according to the personal situation of your patient. And the open questions that still remain, and this is working in progress, that is still to be done, is to analyze at the basic level what is the origin of this cell-free DNA, which part of the embryo comes from, and also what is the mechanism. And we are doing this with the Nicolas Plachna laboratory. Nicolas Plachna is one of the most important embryo imaging researchers in the world. And we are trying to do this with him. And also we are undertaking now a randomized clinical study on clinical outcome comparing morphology versus cell-free DNA alone. These are images from Nicolas Plachna. What we know already is that this cell-free DNA is a real DNA reflecting the chromosomal status of the embryo. Nothing to do with apoptotic DNA, but we need to know where this DNA is produced, transferred from one cell blastomere to the other, and how this is secreted. So we try to pursue the understanding of this, and together with this randomized clinical trial in which we have already these 15 centers involved, aiming for an increase of live birth rate of 10% between the intervention group, which basically is the intervention group, which basically is to transfer the embryo according to cell-free DNA analysis, and the control group, which will be just based on morphological criteria. So this is what we are undertaking now, and hopefully in 1 year we will be able to give you the result about this. These are the centers that they have already committed their work in this clinical trial worldwide, and the idea will be to have this 872 single embryo transfer in order to follow up the clinical results. So in conclusions, what I would like to give you from my presentation is that the cell-free DNA secreted by the human blastocyst can be analyzed and amplified by NGS, and it is representative of embryo chromosomal content. Concordance rates that we have already obtained between trophectoderm biopsies and cell-free DNA have been found as high as 85%, with a mean published nowadays of 78%, at day 6 of embryo development. We are not talking about day 7. We are talking about day 6, and the last part of the embryo development should be done in about 30, 40 hours to be able to get enough cell-free DNA for the analysis. There is a high concordance rate of cell-free DNA in the culture media with the inner cell mass. Embryo cell-free DNA analysis would allow first to prioritize embryos to transfer according to their aneuploidy risk, considering the age of the patient and the situation of the other embryos that they are present. And of course, this strategy has been worked in order to avoid embryo biopsy and the conflict of discarding potentially euploid embryos in PGT-A. And with that, I just want to mention that this is the work of Carmen Rubio group that has been working this for the last 5 years or so, together with our clinical team that has been managing and controlling the clinical studies, and with the help of Nicolas Platzna that we are trying to do the basic work with his collaboration in a joint project with his lab, and also, and of course, all the colleagues from Igenomix worldwide. Thank you very much for your attention, and I will be happy to entertain any questions that you may have.
Progesterone is a steroid comprising of 3 cyclohexane rings and 1 cyclopentane ring. It is manufactured for therapeutic use from the wild yam root Dioscorea species. Due to rapid first-pass liver metabolism, progesterone has variable concentrations and very low oral bioavailability. Therefore, it is administered via injection or vaginal route, which are not easy to use and associated with side effects. Dydrogesterone was introduced for clinical use under the trade name Dufeston in the 1960s for treatment of conditions associated with progesterone deficiency. The manufacturing process of dydrogesterone is highly complex. It starts with the chemical modification of progesterone, followed by a critical phase of transformation into dydrogesterone. This is done by passing it through UV light at an appropriate wavelength, intensity and time sequence, resulting in a unique, modified retrosteroid structure. This manufacturing process makes dydrogesterone the only commercially available retroprogesterone. The bent conformation of oral dydrogesterone enhances the rigidity of the molecule compared to progesterone. Due to its unique structure, dydrogesterone is highly selective for progesterone receptors, supplementing deficiency of endogenous progesterone. It has negligible interaction with other steroid receptors, resulting in a lack of androgenic, estrogenic, glucocorticoid and mineralocorticoid effects that can occur with other progestogens. Dufeston, containing 10 mg dydrogesterone in each tablet, is formulated to have good bioavailability, enabling convenient, patient-friendly oral administration. Improved oral bioavailability and the receptor agonist activity of its metabolites causes secretory transformation of the endometrium, progestational activity, at a dose 10 to 20 times lower than micronized progesterone. Various progestogens have been investigated to support endogenous progesterone in the treatment of luteal phase deficiency. Only Dufeston, progesterone, and 17-alpha-hydroxyprogesterone caproate are currently approved for clinical use during pregnancy. In addition, Dufeston has a wide range of indications to supplement endogenous progesterone deficiency. It is shown to be effective in irregular menstrual cycles, dysmenorrhea, endometriosis, premenstrual syndrome, and secondary amenorrhea. In women undergoing assisted reproduction, Dufeston supplements endogenous progesterone and provides orally effective luteal phase support, contributing to successful and comparable pregnancy outcomes versus vaginal micronized progesterone. To date, Around 113 million women throughout the world have experience with Dufaston, including 20 million fetuses exposed to dydrogesterone in utero.